Hey there, it's Chris Mack. On today's episode of Murse Monday, we're going to talk about being a new hire working in the ICU. And the reason that this subject comes up today is because myself and one of my fellow coworkers, we were recently voluntold into precepting several of the new hires that we have just gotten at our hospital. Her and I had an opportunity to talk about this earlier this week because we start precepting this week coming up. We talked about the three different types of hires and which ones we would personally want to take on. So first, what are those three different types of new nurses working in the ICU? First, you've got new grads who've never worked anywhere. Then you've got new hires into the ICU who have prior nursing experience but not in the ICU, so they could have worked tele or med surg or even long-term care or something like that. And then third, you've got hires into the ICU who have prior ICU experience but are coming from a different hospital facility. So let's dive into each one of those and then kind of the pros and cons of each, and whichever one you fall into, hopefully there will be some pearls of wisdom in here, and if not, sorry, I'm just kind of taking a shot here because not everyone's going to fit into everything that's being said about every group. So let's start off with the new grads. From a preceptor perspective, having a new grad is good and bad. It's good in the fact that new grads, there are no bad habits to break. There's no like, oh, well, I only do vitals this so often, or I don't like giving medications this way, or I feel like I would rather do it this way, or my time management, I prefer to do it this way. You're a blank slate being a new grad, which is a really good thing. On the downside is that being a new grad, you don't know what you don't know, which is absolutely fine. We all have to start somewhere. And let me give you, if you are a new grad watching this, then let me give you an example of something that I did that was kind of like you don't know what you don't know. And that was whenever I got started working in the ICU and my preceptor was teaching me. My patient was having frequent PVCs, and my preceptor wanting to coach out of me like, hey, what should you do? Critical thinking, what's next? She asked me, so your patient's having a lot of PVCs, what are you going to do? And I was orienting on night shift. I was tired. I was a new grad. I didn't know anything about anything whenever it came to that. So I was like, oh, okay. And I went and changed the PVC alarm. And luckily my preceptor and I had a really good relationship where she was able to, hey, check a potassium. I was like, oh, yeah, that's right. Sorry. So it's one of those you just have to be willing to learn. And that's kind of about it. The other thing is that if you are a new grad starting in the ICU, don't feel like you have to know everything, because I guarantee you any preceptor, any coworker, any fellow nurse, any manager, any charge nurse, they would all rather you say, I don't know the answer, than sit there and mumble and try and make one up. Okay? So those are kind of my words of wisdom and advice and kind of what it would be like as a new grad. Being a nurse coming from another department, but not having ICU experience, there's good things and there's bad things about that as well. So let's start with the good. Floor nurses have phenomenal time management skills because they're dealing with a lot of patients versus the smaller amount in the ICU. But that's good and bad. It's good that you have time management skills, but on the flip side of that, you have to also take into account that while you might have 5 or 6 patients that are kind of okay or really okay, and maybe out of your 5 or 6, these 2 are going to discharge, these 2 are awaiting like a long-term care facility rehab kind of a deal, and these 2 are the 2 that you kind of, they're not real sick, but they're sick enough that you might do an extra check or 2. In the ICU, all of your patients are that sick, and then some. So you have to learn that your time management skills aren't just well, here's my checklist, and I need to check this, and I need to check that. That checklist can get thrown to the wind in a matter of seconds. So that's kind of the difference. But like I said, coming from a different department means that, one, you've already got that knowledge and foresight that you probably know a lot of the doctors and what they're looking for anyway. Secondly, you've got great time management. Third, you've got some common sense nursing, which is great. And by common sense nursing, I mean, from working on the floor, you already know that if you call a physician at 3 o'clock in the morning saying, hey, your order set says you want the patient's blood pressure above 90 systolic, I just wanted to let you know it's 89, what would you like me to do? That kind of stuff gets old very, very quick. called common sense nursing. Was the patient completely asleep? If you went in and be like, hey, I'm going to check your blood pressure, and then wake up just a little bit and you run it again, is their blood pressure now 120? It's an easy fix. Or secondly, would just run the cuff again. So that common sense nursing is something that floor nurses have that new grads definitely do not, and that is something that is absolutely amazing. Third group that I want to talk about are those who have prior ICU experience, but not in the facility that you're working at. And being that I've done that route as well, I did work in Virginia and now I work in Colorado. I only have 2 words of advice. One, if you're training these folks, be courteous and be kind. Be courteous of the fact that they do have a skill set, and be courteous of the fact that you don't know what crap they've put up with already. That said, if you are that one that has ICU experience coming to a new place, also be kind and courteous back, because you don't know the physicians, you don't know the phone calls that they do or do not want, you don't know how they do certain things. So let me give you an example from myself as well. So in Virginia, if we were giving meds through a PEG tube or a G tube or NG, whatever we're giving meds down that weren't strictly orally, we would take a clean specimen cup, crush our meds, throw them in there, and shake it to dilute it much faster, so that way we could get done, because we've got more important things to do than sitting waiting for meds to dissolve in a cup and stirring it and hoping none of it falls out of that little 30 ml medicine cup. So whenever I came out to Colorado, and the first time I did that in front of my preceptor, she was looking at me like, what the heck are you doing? I'm giving meds down an NG tube. That's what I'm doing. And so know that while things are done differently, try to not come off cocky and saying, hey, well, this is how I've done it and this is how I want to continue to do it. I'm not saying that's wrong. Just make sure you are doing so in a polite manner and not coming off cocky, because I came off cocky. And I didn't mean to be. And so just try and roll with the personalities of the people that you're working with, because I'm sure you've had your bad experiences, they've had their bad experiences. Everyone is experienced here in this particular scenario, just they have different experiences. So just be willing to work with them, because whenever it came to my part, whenever I would say, no, I've got this, I understand, no, I've got this, I understand, no, I've got this, I understand, that wasn't to be cocky, but that's how it was perceived. For me, whenever I was going down through the checklist of like, hey, you're a new hire here, we've got to check all the boxes, my saying, hey, I got this, wasn't being cocky. Mine was the, nope, next, next, next. So that way when we hit something like, okay, wait, that one I don't understand, let's talk about this. My being blunt in the, nope, this one I've got, wasn't an act of cockiness. It was an act of, when I come to something I do need you to explain, that's me truly telling you, I don't understand, and I need you to tell me what you want me to do. And I need to understand how you want me to do that based on how your doctors work. So just know that there's nothing wrong with your experience, and while some nurses could possibly give you a hard time for it, don't take it personally. That's going to be on their end, but at the same time, know who you're working with and be polite. All right, I think I've rambled on enough about this. If you've got any questions, comments, or concerns, and go ahead and leave those down in the comments below. I will try to get back to them as soon as possible. And also, if there are any other video ideas that you would like me to go over, I did some IV tips. I did a Lopez valve tips video. So if there are other things that you would like me to talk about, please go ahead and leave those down in the comments as well. And I kind of think that's it at this point. So thank you so much for your time. Again, my name is Chris Mack, and I'll see you next time.